This is what I'm saying. Subperiosteum. Subperiosteum is very. We have 10 more slides and we're done. Okay, we're talking about sinus a little bit now. We're done with the one drill. I'm just kind of share with you one drill, immediate implants, and then a failed implant, how to replace it, explant, replace it, same time. We're talking about sinus. You have to understand, during my time is really a frustrating year. Why? During my time, my professor told me, don't touch sinus. Scary, you get lawsuit, whatever. You just scare the hell out of me. So whenever I'm gonna do sinus in an implant, I just tell the patient, hey, you're not a candidate for implants. That's pretty much my professor taught me, you're not a candidate for implants. So then later I learned how to do subperiosteum. Subperiosteum means you cut the gum wide open, expose all the bone, you take the alternate impression or maybe any kind of impression material, then suture it. With that bone model, you go to the lab. Lab made you look like a mesh, a net, wire. So come back later, a month later, you open that gum again and put this metallic net inside and then suture again. Okay, so this implant is embedded between bone and gum. That's why I call it subperiosteum. And what that is that what that does is will not invade the sinus because it's all between the bone and the gum. So I've been taught that is the standard care. That is the gold standard. Okay, you know how frustrated I was then. Let me go to this one. Then a year later, somebody said, Zygomatic implant. I said, wait. Last year somebody told me sinus is scary, don't touch it. Oh, don't worry about it, just go through it. Never happened, don't worry about it. You saw how frustrated I am as a student. I just freshly graduate. You tell me, be careful. Then this guy told me, don't worry about it. You know, so anyway, we call it zygomatic, don't worry about it. Okay, what do? They go to the zygoma. They go straight right to zygoma. Now, if you're a patient, will you come back again? What if one implant fail? What am I going to tell the patient? I have another size I can put it in, not tell anybody? No, this whole thing going to come out. Okay, we call it zygomatic implant. So is this the present? Is people still using this? Yes, people still using it. So you're gonna say, why are people still using it? Well, let me give you another funny story. Remember I told you there's a doctor there's the group of a doctor or surgeon using a hip bone, then to the shin bone, then to ramus. There's one doctor in San Diego. He's the only one in the world. Okay, he gets blood bone from skull, from cranium, and you say, wow. I went wild too, but patient loves him. I had 2 patients came to my office. Whenever a new patient comes to my office, they move from San Diego to Las Vegas. I walk in, hey, how are you? I shake his hand. And this one lady, one time I shake her hand. She grabbed my hand, did not let go. I was like, oh, what? And she just, feel here. It was a big indentation. And I was like, oh, you're from San Diego? Yeah, how do you know? And then she goes like, Dad, it's here now. And I looked at it and said, but you're here today for infection there, right? So what bone is that? That's still a bone. It's not a bone will help you think, okay? So what I'm saying is people like a niche. The doctor always have a niche of the practice. I'm the only one in the world dare to touch the skull. Okay, congratulations. I'm not that doctor. Okay, but anyway. So don't get so impressed by many doctors tell you, hey, I can do this bloody surgery. Congratulations. I don't know how many patients you have, but in my practice, I don't see blood much. Let me think of this one, okay? This doctor from, okay, this is a canine. What's behind canine? 4 teeth. 1, 2, 3. You're missing one. Let's look at Canine. 1, 2, 3, 4. What's this? Then this patient came to me and I said, wait a minute. Are you numb here? She said, yes. Oh, which implant that killed the nerve? That extra one. And you're missing one implant here. That's why you fracture here. You fracture the implant. If that implant was here, you probably would not fracture this implant. You know, I'm not trying to talk about this doctor is no good. I'm just saying that logically, I'm thinking, this one should be here. Or this one come in, you know, this 4 should be here, 2 should be here. And I know why. If this patient, now I just want to share with you, you need to, can he buy here? Can he use this side? Can't. So with that kind of money, why don't you put this 2 up here? Am I making any sense? Why don't you just do 1 implant, this 2 move it up here? So at least you get more occlusion. Why do you do this and not do this? Why? Because you're afraid of sinus lift. So this doctor just do whatever money he can make. That's it. Not doing patient any service. Let's look at it. Canine. 1, 2, 3, 4. What's this? And then, you know what? The funny thing is, can you restore them? Impossible. So this one had to put asleep. So then the patient asks the doctor, then you put this asleep, what do you charge me for implants? Oh, I want to enforce your jawbone better. What? Why do you enforce jawbone better with extra implant there? It's run out of excuses, okay? Another one, mini implant. Why do you do mini implant? You're able to do all regular implant at the same time. Okay? All right, just last, this is what we call it zygomatic, 014, 015, whatever. Then denture. Okay? What I like to share with you is this is very, very common right now. Everybody's talking about it. But they fracture a lot. Not the implant fracture, denture fracture. Okay? And also oral hygiene. If you have a periodontal infections, it goes all the way in now. All right? People still doing this. Getting a bone from a tibia. Why not just get it from a jar, from a can, from a bottle? No different. Okay? So if somebody is going to show you this, just clap hands. That's all. Don't need to try to learn how to do that, okay? Sinus, you can look into, this is my article. I invented a hydraulic sinus. This is little animation, how to do it. Usually we do the buccal window, lateral, we call lateral window. I use it as a hydraulic using water pressure to make the membrane loosen. So then you can just place a bone in there and place implant at the same time. Around the water. Okay, so that's the animation that's showing you how to do hydraulic sinus. I don't do this anymore. Okay, this article was back in 1997. But a lot of people said, "Well, Leon, you disappear." You know, ever since this invented, many doctors, companies start coming out with the internal lift. Internal lift means from the mouth, from the inside, not from the buccal lateral window. It's from the crestal approach, using balloon, hockey stick, whatever they come out with. They all same thing from the internal crestal approach. Ever since this was invented, everybody coming from that direction, going to that direction. Now, some people was questioning, Leon disappeared because I don't give a lecture anymore. But no, actually, in this 20 years after this was introduced, I came out with a sinus implant. And I kind of silently just use it myself. I didn't want to tell anybody because it's such a great way of doing it. Okay, sinus implant. This implant is a tool. This implant is a sinus lift tool. But as this tool goes, normally we use a tool. We place a bone in there, then we put an implant in, the housing that implant. No, now as we place the lift the sinus, that is a tool. That tool is the implant. So as we place the tool, once we've done that, we just leave it there. That is the implant. Think of that, okay? So now, the design of this implant there's a dish here, a bone nose dish, like a bone carrier. Now, if you look at the thread design, all these thread is clockwise, going up. But this is a reverse thread. What that means is as the implant inserting in, all the autogenous bone being cut off, shaved off, being pushed to sinus. Okay? So this is a pattern. So you look at it, let me just share with you. This is a board here. It just already has a osteotomy, if you think of osteotomy. So yes, I just place the implant in, as I just kind of place the implant. So the motion is the same, I'm just placing implant. But if I turn it around,
有在拍吗？拍照。给我拍照。可是太长会不会？我
you probably think I'm just placing implant. But as I turn it around, look at it, this side of the board, that's a sinus. All the autogenous bone is being pushed to the sinus membrane. Okay? So I did a sinus lift simultaneously, implant placement at the same time. Okay, and then look at as I keep pushing it, it just keep pushing the bone up to the sinus membrane. So we're able to do immediate extraction because the design of a step locking, it locks the implant really well. Then with the bone nose dish, I was able to immediate extraction, place 3 implants, and the implant will do the lift work for me. So that's it, we're done. And so happened, this implant, I call it Sinus Fuse. This implant actually is we call it sinus implant. Actually, FDA approved sinus implant. I'm the first one approved sinus implant. So in other words, legally, all the implants that are in the sinus is not legal to be in there. I am the one legally in there because sinus implant, listen, it's just an implant. Okay, you look at this. Only 1 millimeter, maybe 3 here, or maybe more. Okay, there's a little dip here. 3 implant, all lifted up. Did you do any bone graft? None. As you inserting the implant, you just bring all the autogenous bone up to the dish. Right here, extraction. Oh no, right here. No, there's a wisdom tooth. I don't. Right there. So the motion of placing implant is the same. Just push it. Insert it in, but what you did a sinus lift. Look at this one, only 1 millimeter. I took it out, immediately place it. We gained this much, 10 millimeter, and we were able to restore it. Okay. Mommy did this. It's about 4 millimeter. Did she do a sinus lift? No, she didn't do it. She just insert 3 implants, but that 3 implants itself lift the sinus for her. So we're done. We did everything. So did I charge the sinus lift? Of course I charged the sinus lift. I lifted. This is even easier because if there's a 7 millimeter, then it's even easier because you just do an osteotomy to 6 millimeter, then stop. Then let the implant does its work and you'll lift it more for you. Okay? Same thing here. And we'll just go faster. Anyway, this is just one of my articles. You can see before, only 1 millimeter, this much gain. Only extraction, this much gain. Okay, this last slide, you can see it. I took this tooth out immediately. You can see this. That's a tooth I took out. And immediate place the implant. And it gives all the primary stability so we can put a heating abutment. 4 months later, we restore. And the surgery takes only 7 minutes, ER time 4 months. And I had a little hard time to take this tooth out because the root fractured. You know, whenever you do a root canal, sometimes the root gets so sticky, the root fractured. So as I took that tooth out, one of the root fractured inside. So. But I want to share with you is, he was listening to the music 1 song and a half. 7 minutes and 46 seconds I finished it. Okay, so I try to just hand drill the bird, drill off the root, the one of the root tip that broke inside. Okay, this is last. Anyway, any questions? You can just keep watching it. Oh, sorry. Good luck in your graduation. When I come back in your graduation, I'll see you again. So even though, I mean, let me just give you a little, even though the surgical kit looks so complicated, has so many drills, but actually you can look at it, any drill here, you don't use, many other drill, you have to use this one, keep increasing, so all the drill touch the blood, right? In this surgical, actually, you don't even need, you can sterilize once and pick up this one drill that you're gonna use. The rest of it, you don't even need to touch it. And just this drill, and then the implant, we're done. So if today happen to have 3 patients, and if you use other system, you need 3 sets. Who's gonna buy 3 sets? So usually what I did is, sometime I have 3 patients back to back. Usually I just pull out, this patient needs 11.5. I just pull out this drill for him, and this patient needs, I just kind of spread out. So then I don't need to buy 3 surgical kits just for 3 patients if you happen to jam up the patients in one afternoon. So it's really easy to think of it, the concept. So you can kind of just play with it, okay? And now I have another pattern. It would, the handpiece here, the head. Once we place the implant or drill, we lost the orientation. We lost the orientation. So that handpiece, I cannot go back much there. The handpiece, I have a pattern, has a line here on the head. So now as we place the implant in, everything disappears. At least I can look at a handpiece line, so I know I'm straight down or to the left, to the right. I still can see it, okay? But anyway, just kind of let you know it's coming out. You're gonna see it. Anyway, I finished the implant, sinus lift at the same time, and I placed a heating abutment. And 4 months later, here's the implant. Okay?
I have a question.
All right.
One picture, the sinus was very thin. Another picture, there was a lot more bone. Was there some sort of bone shoving up there with the implant at the same time?
One picture was original bone or when I place it?
What?
Start out originally very little bone?
Yeah.
Or
it was started out with no bone.
Start with no bone. You mean multiple implants?
There was one picture with thin ridge.
Well, because this you have uniformly about 4 millimeters.
No,
so,
one that was thin.
So you'd be looking at
the one with 1 millimeter.
This one, 1 millimeter.
No, thinner. There was a thinner one. This one.
Yeah. Oh. Yeah.
There was some sort of bone shoving at the same time.
There's what?
Bone
pushing up at the same time. No, this implant will push more bone.
And another one.
Oh no. This one is this. Sorry. This one is this one. So actually, this one push more bone. This one's here. This one's right here. This is this one. So this one did not do any sinus.
But the 2 on the right.
Yeah, this 2.
Bone on top,
Yeah, they're more bone. Yeah, because the implant design has a concave dish.
So you put bone on the dish.
No, as you place the inserting implant, the reverse cutting, it push the bone. Instead of washing the bone out, you push the bone to the dish.
But there was enough bone on that tiny thin ridge on the left
Yeah.
to push it up.
Yeah, that's enough. What's enough is bone to implant contact. That's what we care about. We don't care about all the bones somewhere in the other street. We just want to know the bone around the implant. Okay? Let me see. This is reverse cut here.
Yeah, I understand that part.
Yeah. Now you have to understand the advantage of this is not just pushing the autogenous bone up. Remember, I just mentioned to you, you take the bone outside your body for half minutes, 30 minutes. That bone is really nothing there. It's gone. It's already vaporized, all the protein. This is an enclosed area. As I cut off the bone did not leave the body, not even expose to air. It just got pushed underneath the sinus membrane. So I preserve all the integrity of all the protein of the bone, of your own bone.
So all the bone around the implant.
Yeah. They get pushed up.
But up and also to the sides?
Also to the side. And why goes to the side? Why did not go over here or somewhere there? No, because the patient is breathing. So patient will help us compact the bone down. Okay? Make all the sense? Did I open all your mind? So implant is fun. Enjoy. Okay?